Hi, everyone. Welcome to this edition of Family Medicine on Air. Thanks for joining us. I'm Sam Carlson of the AAFP, and I'd like to introduce our host for this episode, Crystal Foster. Crystal is a fourth-year medical student at the University of Missouri-Columbia and the FMIG Network Region 2 Coordinator. Crystal, take it away.
Thanks, Sam. Welcome to Family Medicine on Air, the American Academy of Family Physicians and the Family Medicine Interest Group Network, bringing this social media series to give medical students across the country a chance to learn about hot topics in healthcare directly from leaders in family medicine. Like all episodes of Family Medicine on Air, this video will be archived on the FMIG Network's YouTube channel and Google Plus page, and we have some additional resources and information we'll share with you in a little bit. Today's episode is titled What Medical Students Need to Know About Cost of Care. Here to tell us more about it is AAFP President Dr. Robert Wergen. Dr. Wergen is a family physician from Milford, Nebraska, and is current president of the AAFP, having previously served 3 years as director on the AAFP board and 1 year as president-elect. In addition to practicing full-spectrum family medicine from OB to geriatrics in his rural hometown, Dr. Wergen is also an active member of his community, serving on the board of Milford Public Schools Foundation and serving as medical director for Milford Volunteer Fire Department, team physician for the Milford Public Schools, and sideline physician for the Nebraska Shrine Bowl. Dr. Wergen is also an educator, serving as an instructor of advanced cardiac and advanced trauma life support at Milford City Physician. As a Milford City Physician, he also serves as a volunteer faculty member at the University of Nebraska Medical Center, teaching medical students and residents on rural rotations. Dr. Wergen was awarded the Nebraska Family Physician of the Year Award in 2002 and Nebraska Nursing Home Medical Director of the Year in 2012, as well as the AAFP Degree of Fellow, an earned degree awarded to family medicine physicians for distinguished service and continuing medical education. I'll turn things over to Dr. Wergen to tell us about cost of care, and then come back with a few questions submitted by your fellow medical students.
Well, that's great, and I appreciate to get this opportunity to communicate with students. And this is a very pertinent topic that sometimes during your medical school rotations and with preceptors, you don't always think about it. You're more focused on the differential diagnosis and how you arrive at the cost. But with the modern pressures we have on healthcare delivery in this country and trying to get to the triple aim, which is 3 things. Triple aim is, number 1, better care, better health, and a lower cost. That's what I say. So as you go through rotations and you look into, gee, how do I come to the diagnosis? Your patient, your history, your physical exam often gets you to narrow it down to a group of what you think is best. Of course, it may change depending on what the tests are. And as you order tests, you want to choose the right test. And one thing I often tell students is think ahead. Like, if I order this test at this point in time, you might even look into what are the costs of that test and what will I do? How will it affect my treatment plan that I'm going to set up for this patient if it's positive versus negative? So in some instances, you may do a test and say, well, if it's positive or negative, I will probably do about the same thing. In other words, in terms of my treatment plan. The other thing is, does this test need to be done right at this moment in time? And some of that has to do with in the differential, if the consequences of the differential diagnosis is very severe, say death or marked morbidity, that test probably is worth doing and carrying further. So sometimes you have to look at the odds of what the tests you're ordering, either laboratory or particularly imaging tests, and see what how that might affect your treatment plan. Now, we know as family physicians, being comprehensive whole person, that there's been many studies over the years, evidence-based studies with our patient-centered medical home studies. Recently, the Patient-Centered Primary Care Collaborative Group, which is a group of CEOs of the major businesses of the country who want to move us towards primary care, team-based care. They just came out with their report last Friday, and interestingly, it showed those patients who were seen in the setting of patient-centered medical home, team-based care with a primary care physician who either provides that care directly or coordinates the care, results in better outcomes at a lower cost. I might repeat that. Better outcomes at a lower cost. If you were a politician, that really gets your attention. And primary care has been rediscovered in our country, and we're ready to move forward. We have been the only participants in the program, which I may address a little more lately, Choosing Wisely. It was a program set up by the American Board of Internal Medicine. We're the only professional group that's participated in all three phases of it. And what it is what tests are appropriate, what's the timing of those tests in terms of do you do them right away or later, what's the evidence tell you to do that. But I want to emphasize to all you as students, as you go on and develop this clinical acumen and knowledge that you have, there are some things that outlie an algorithm, meaning these are standard tests, low back pain, waiting 6 weeks before doing any back imaging. Well, that's probably a good rule of thumb. But if your assessment of that individual patient, I can give you examples in my practice. The patient's lost a reflex, he can't go to work, he's got foot drop. That's not the standard back pain. You may move into, again, use your clinical judgment to say, well, in this case, maybe I'll do that imaging earlier in the course, particularly if the patient's not getting better, so I can get him back to work. Again, that takes clinical judgment. But in general, the Choosing Wisely tests are evidence-based guidelines to say what tests should be done, what the timing of it, or maybe what tests shouldn't be done. So I think family medicine and primary care is moving to going to be the basis of our healthcare system in our country to deliver that high quality, cost-effective care in our country, just as it has in every other developed country in the world. If you look at Europe and particularly Denmark and those countries, they tend to have better outcomes at much less cost. The Commonwealth Fund does a study every year. We were 11th out of 11th of all developed countries in terms of outcomes and spent about 2.5 times more than those other countries. Is our care not good? No, it's good. It's the timing and the focus of it. If you have a primary care physician who can provide that primary care, looking at you as a whole person, being comprehensive, and in the instances that I can't provide that care, say dermatology, which Crystal, I know you're on, Mohs, chemosurgery, I'm not going to do that, but I know the dermatologist that I can direct you to and coordinate that care. So that's kind of an overview, and as a student, trying to discover what do tests cost, and sometimes asking the ward clerk, and then asking yourself, how is this going to affect my clinical decision tree? If it's going to be critical, boy, in my differential, this will have a very bad outcome. If I don't make this as an early diagnosis, might be myocardial ischemia, pulmonary embolism, you might move right ahead to doing the imaging or the tests it takes to do that. But in my own practice, in Melford, Nebraska, I know my patients. I can see them. If the differential is in death in there, I can say, let's try these things, and you come and see me in 2 days or in a day if you're not better. That's part of that relationship and continuity of care that can deliver that high-quality care that is cost-effective because we know our patients, they know us. So I'll be available if you have any questions for me, Crystal, or I can expand on any of the things if you'd like me to about the cost effectiveness and being cost effective as a provider.
Sure. Thanks, Dr. Wergen. I do have a few questions that were submitted by students through their FMIG Network
Great.
Regional Coordinators. So we'll kind of start with the first question. What are some ways that we as medical students can learn more about cost-effective care as part of our rotations, especially since some preceptors do a better job than others with considering costs? And then with that, what's the most important for us to learn to prepare us to not to add to the problem?
Well, that is a good question. And again, I'd go back to what I said earlier is sometimes asking the ward clerk or even the Department of Radiology, the billing people, what do these tests cost? Not that you won't do them, just so you're aware of what they cost. The second issue is the right test at the right time for the right diagnosis. And So as you ask yourself, if I'm ordering these tests, even though no matter what they cost, but particularly more expensive imaging tests or whatever, how is that going to change or affect my medical decision making and setting up my treatment plan for this patient? Remember, it's also within that mix of that differential diagnosis you're developing to try to get at the base of that patient's problem. The other thing is primary care doctors or as family physicians, we do whole person approach, often know the patient. You can take that into the context of your decision making. Maybe I can delay doing this imaging for a period of time. I might know the resources as a primary care doctor of that patient, saying, gee, this person has a very high deductible. If I select a medication, maybe I should pick that $4 Walmart list drug, which also spills over to other pharmacies. These low-cost generic medications, if they can fit and meet the needs of that patient as well as maybe a high-cost name brand medication. So being aware of the $4 list, having it printed out, knowing the dosage of those. But again, you want to do the best care at the right time. Maybe that wouldn't be an option depending on what your differential in that diagnosis is.
Thanks, Dr. Wergen. We have a couple more questions here.
Sure.
So what are some areas in which family medicine can improve in terms of cost-effective care?
I'm sorry, could you repeat that? I didn't get the first part of it.
Sure. What are some areas in which family medicine can improve in terms of cost-effective care?
Well, I think I mentioned the Choosing Wisely, being aware of the programs through our academy. And the Choosing Wisely program is looking at testing, at what's appropriate, and the timing of testing that's evidence-based, not just saying, gee, this would be nice to know, or that. What's the literature say is the best sequencing of testing? So Choosing Wisely is a good program. Also, we provide a lot of resources for both patients themselves to say what's appropriate. I get patients say, doctor, don't I need an MRI of my back? Because I've read about it and say, well, maybe not now, maybe not at this point. Let's try these other things. That's going to be very expensive. You have a high deductible plan. That's going to be a lot of out-of-pocket expense for you. Let's do these other things first. But we may arrive there if you don't get better. So family physicians can usually use more evidence-based guidelines in terms of their approach. But I want to qualify that with knowing the patient, their families, that continuous experience you have with them. It may alter even how you intervene. And often you'll arrive at the best care and the right testing at the right time and the right cost, even coordinating their care as they go to other providers. What you're going to find out as a family doctor, they'll see the cardiologist, the pulmonologist, and both of them order an echocardiogram. Well, they don't need 2 echocardiograms, so I'll usually call up one and say, well, no, you don't need 2, just get 1, and we'll send that one to both of them. But then the information for that patient and the treatment plan flows through a provider. Interestingly, if you look at some of Barbara Starfield's data, late 90s, early 2000s, will show that just having that, someone who knows you, follows your care, you get better outcomes. Her study at University of California, San Francisco looked at primary care doctors who admit their patient, follow them through their entire stay, and she looked at a hard outcome, death. So you can look at other quality measures and maybe fudge them if you have an agenda, but probably death, you're either dead or you're not. And your chance of death was statistically less, no matter what the diagnosis, having that one thing, having your doctor who knows you, follow you through the course. Interestingly, all the quality measures were higher, and guess what? The costs were less.
You had mentioned just a little bit ago about patients asking questions and saying, could I get this MRI? Is there a resource that you send patients to learn more about the cost of care and kind of understand where we're coming from?
Many times their insurance provider can provide what the actual out-of-pocket costs are for them, particularly now in this era of high deductible plans through the marketplace. Another resource is FamilyDoc.org. They I give them that as a website to look at, to say what's the appropriate care, the timing of that care. It doesn't always list the cost, so sometimes they have to list that back to the insurer. Sometimes asking the physician, that may be one of our responsibilities as a student, as a doctor, as a resident, to kind of have a general idea of what things cost. Interestingly, in today's environment, with imaging, sometimes doing outpatient imaging at an imaging center may be substantially cheaper for an individual. In my practice, I am in an agricultural farming base, so small businesses. Many times they have high deductibles, so if a test costs $1,000, it costs them $1,000. So I, for them, kind of look and know, well, the Advanced Medical Imaging Outpatient Center is $800 less than the other. So being aware of what your local community resources are. If you're in the hospital, you're kind of stuck with that. But and then directing the patients to those lower cost resources and still getting the same MRI, the same information that you need to provide the best care for that patient.
Thank you, Dr. Worgan. I think that's all the time we have for this episode. If you'd like to learn more about the cost of care and other hot topics in healthcare, head to aafp.org/fmonair. There you'll find supplemental resources for all the episodes. And then, again, for being here today, Dr. Worgan, and thanks to everyone for watching. Stay tuned for the next episode of Family Medicine on Air.
Thank you. Great topic, and hope you work hard in your classes, and you'll all be great family physicians and provide high-quality, cost-effective care. Our future's bright.